our brains are changing from birth. And if we can recognize that change and use it as a tool, then we'll be able to change every time, every stage of life.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 75 of the Strokecast. Shortly after I got out of the hospital, a friend and former coworker sent me a link to an announcement from Valley Medical Center in Renton, Washington, about the Stroke Club. Despite the commute from downtown Seattle, this would become the first stroke support group that I attended. It's there that I met Sarah Devine, a neurology nurse practitioner who led the group. This was over a year ago, and since then, the group has grown, and we've heard from an assortment of speakers. Attendees have come and gone. And now, Sarah is handing over the reins to the group while she prepares to take her own very well-deserved break. Before she leaves, though, I wanted to sit down and talk with her about her own story and path and how she came to run the Stroke Club and live the life she's living. Sarah Devine is an adult nurse practitioner practicing at Valley Medical Center's Neuroscience Institute. Sarah sees stroke and TIA patients in the hospital and clinic to confirm etiology, reduce risk for re-stroke, and counsel patients on lifestyle changes while helping them through multiple post-stroke syndromes and symptoms that occur. She supports stroke survivor programs, including encouraging Neuro Tai Chi programs, has run Valley's Stroke Club for the past 4 years, and sits on the board of Tango Stride, Tango for stroke survivors. Now, let's meet Sarah. Well, I'm always fascinated at people's paths. So, how did you get into the medical field?
So, I kind of had a vision as a very little girl of being in a white coat and a stethoscope. Very little. Like, I think our early first dentist was a woman back in the 1960s. Born in Portchester, New York. There was a woman dentist there, but mostly after childhood, I was in the humanities. That's kind of my family's angle. We're huge readers, big into history, and I studied American studies, literature, and art in college, my first round. But my mother was a nurse in Britain, and there was always those stories of she was a nurse right after World War II. A lot of interesting work that she did, and it seemed like there was a lot of freedom she had a lot of freedom of movement. She nursed in different countries, different places.
So was she actually nursing in the war, or did she enter the profession after the war?
No, she was a nursing student during at the end of the war, and then she did a lot of interesting work in veterans who were burned in the early kind of plastic surgery, burned veterans in Britain, a lot of pilots, and they made huge progress then in the 1940s, 1950s. But her brothers were in the war, but she was not a nurse in the war. In any case, eventually I did a lot of interesting work in the humanities, but not well paid.
Sure.
And, I was traipsing around the world and the country and eventually landed here. And I just didn't like office work. I just felt too sedentary. And so I was kind of trying to figure out how I could be both social and moving and do something with my brain. And I kind of landed on nursing. And I did that for a while, and then for 15 years till I finally was able to go back to university and get an advanced degree and become a nurse practitioner.
Gotcha. So when you were growing up, were you then involved in the work your mother was doing, or was that pretty much strongly separated, or was that just sort of like the medical conversations that happen at dinner?
Totally the medical conversations. because my mother wasn't a nurse in this country. So she wasn't able to be a nurse in this country, but she talked about it a lot. And I think, there's this talk in the nursing world about how if you're the child of a nurse, your leg has to be falling off before your mother notices, or it gives you much sympathy. It's like, take 2 Tylenol and go to school, stop on. And that kind of attitude came across, which is that you're competent and you can cope with things, and it's up to you to help other people cope with things because you have that competence. So, but yeah, the interest in biology, interest in illness, but also health, and as well as history and reading and literature were all a part of everything. And they all kind of belonged together for me. Maybe not for other nurses and doctors, but for me it did. It was all part of the same human condition.
Well, oh yeah, absolutely. And it's fascinating how everybody has their own path that brings you to that and coming up through the humanities. And I think that brings a nice rounding to your background there.
I think so. I think particularly healthy way to come to neurology. If you're thinking in terms only of biology or even genetics, when you're thinking about neurology, then you're not taking into account the person's entire history, which impacts how the brain works, I think.
Yeah, no, that makes a lot of sense. I mean, a lot of folks, they first encounter the term neuroplasticity when they have a neurological event and have to go ahead and rebuild the brain, but they don't think that neuroplasticity is happening all the time, every day, with everything that we do.
Right. And I definitely think that is the thing that it's possible to take away from stroke, which is that our brains are changing from birth to death. And if we can recognize that change and use it as a tool, then we'll be able to change every stage of life in a healthy way.
Absolutely. One of the things that struck me a few months ago, I interviewed Christine Lee, who wrote a book called Tell Me Everything You Don't Remember, about her stroke experience and her experience with, well, among other things, she ended up losing all of her short-term memory and acquired aphasia. And the way she was expressing herself, there's something, again, I don't want to minimize it, especially since it wasn't one of my deficits, but there's something very poetic about the way some folks with aphasia end up speaking.
Yeah, I agree. And it's been an interesting journey. I've only been in this work for 4.5 years, specifically in stroke clinic, but just it feels like, multiple times a year I get it on a better level. and recently I was speaking with 2 different athletes, young men who were really athletic and had significant aphasia, had gone through years of speech therapy, and they weren't interested in it anymore. They found a new place to be, and it was almost functionally mute. But I was walking behind this couple that I knew from clinic. They didn't realize that I had seen him. He was coming out of the hospital. And I realized how well he communicated. I just saw it between them. And not only relying on her, but he had gone on to DJ, and he had gone on, which he had done before, to training another person in weightlifting. Which was what his prior job was too. Only one person, but nevertheless, one step at a time.
Absolutely.
And I thought, communication is so multifaceted that one part of our brain doesn't decide all of it for us. And it was a thing of beauty, it really was.
Right. Yeah, absolutely. Well, I think the other aspect of that too is that, I know I've talked a lot about the key to recovery is having an action-oriented attitude. You've got to want it. You've got to believe it. Believing it doesn't guarantee it, but it is a necessary ingredient. But at the same time, you have to want it. And you can think about it as I think a lot of folks who haven't been through this think, well, how is anything less than 100% recovery acceptable? You know, what I found 2 years later, I'm not giving up and I'm not stopping yet, but if I never got my left hand back, I'm okay with that.
Yeah, it's not the end. You know, it is a road on the journey. And, you know, I'm in my mid-50s and, you know, the body just isn't what it was, you know. I was never an athlete, but there certainly was times when I had a waistline, you know.
Sure.
And I'm not, you know, again, not minimizing, you know, extraordinary, you know, trauma and difficulty, but there is an asset to a certain amount of serenity to find where you are in life and what you want out of that moment.
Right, and how it fits in with your personal priorities.
Right. Reprioritizing all the time. Reprioritizing. This is most important now. And I think you're right. Then you have to want it, but you have to know what you want. You know, you have to know, okay, I want my left hand back because I want to be able to function in this respect, in that respect. Not because I want to look like everybody else, you know, or whatever.
Exactly. No, I think that makes a lot of sense. When I was first inpatient, they asked me my goals, and I'm like, well, I just want to get better.
Yeah.
You know, I should have thought bigger and thought world domination. I don't know if there's an OT protocol for that, but
somewhere.
Yeah, exactly. But now if I go ahead and refine, what is my goal with my hand? Well, if I'm going to assign a goal to it, it's I want to be able to type with two hands again.
Yeah.
And that's an actionable goal, something I can work towards versus getting my fingers back.
Right, exactly. It was interesting, you know, hearing Cheryl, who we know from the Stroke Club, say, you know, years ago that she missed crocheting, and eventually they found a way to give her that, you know, an avenue for her to be able to crochet. But it wasn't that she got function back in both hands to do it. It was that they were able to fashion tools, and then she was able to use those tools. And now she makes tablecloths. You know what I mean? And that was the goal. And the way to the goal wasn't at first what she was thinking, but it still reached the goal. Does that make sense?
Yeah, that makes a lot of sense. And I think that's one of those things that's so important when these things happen, regardless of the deficits. It's about figuring out what is your goal, what do you actually want to accomplish,
right,
rather than what's necessarily the traditional tool for getting there. And when you talk about, you know, her being able to create those tablecloths, when you talk about the other folks who've you were talking about earlier, who've learned to communicate, they've achieved that goal, even if it is without traditional language, or even rethinking things like when I do dishes, now I don't stand at the center of the sink, and it took me more than 1.5 years to figure that out.
Yeah.
I mean, because you stand off to the side, and now my functioning hand is set with the faucet, and it makes it a lot more sense.
And I think, and kind of, it sounds like I'm taking the inverse or the opposite tact, but the work of bringing that kind of conversation to people, like what are your goals and how do you get there, is recognizing that the losses are huge.
Mm-hmm.
Like, yes, the gentleman can communicate. He can use everything to communicate with his music, because he can be a DJ again, and that made him very happy. He can always communicate with his girlfriend because they're, they're close. But not only is the ability to talk gone, aphasia means the ability to really understand as well at least in some respect with everybody.
Mm-hmm.
And that is isolating, and brutally isolating. So I don't want to minimize the loss, because I want to give people the moment to grieve it.
Mm-hmm.
And that grief is, it's a companion. But also want to say, but this isn't it. Grief is not your life.
Right.
There's still those goals, and if we keep both grief and joy in mind, then it's possible to get there. and create new ways of getting to the goals. That's a little heavy, but
No, but I mean that's absolutely the case, and I think when you're talking about where somebody is in their journey too, that makes a big difference. Where you're at 2 weeks post-stroke, 6 weeks post-stroke, 6 months, 6 years, you have a different relationship with your goals, with your life, and with your body.
Mm-hmm, absolutely. I've kind of, over the years, have come up with things that people really need to hear and almost never do, or it seems like they often never do. And I've started to tell people right in the hospital to see if they'll remember, and then when I see them again, and that is, a couple of things happen to everybody on some degree or another. And if you can wrap your mind around those not being static, like those not being the new you, then you have the possibility of improving endlessly. And one of them is fatigue. If you recognize that you're going to be so bone tired that you can't think straight, is not a permanent state, but also it can be managed. Sleep and naps and fluids and everything. And that it's different for different injuries.
Right. Socially acceptable naps is one of the stroke perks.
Absolutely. Free medicine. I tell you, free medicine, My husband's like, I knew it, But, and endurance is slightly, it's connected to fatigue, but it's different, qualitatively different thing. It's hitting a wall where you're done, recognizing that wall. And then cognitive changes are temporary in many, many, many people, but everybody's terrified of it. A week after a tiny little stroke where they're not having any physical symptoms, they think, oh my God, I can't remember my mother's, favorite color. And then they're like, that's it, I'm demented. Unless someone says to you, your brain is stunned, give it a minute,
Right. Right.
And that's an important thing to hear. And it's an important thing to know whenever your brain is stunned again. When you're sick, when you're exhausted, whatever. That's not going to work as fluidly, but it doesn't mean it's all for naught. It's all lost. And then the emotional impact is there. So those 4 things I want everyone to know. It's jump the queue into question.
Yeah, no, absolutely, absolutely. And that stuff is so important. And
critical.
The emotional lability that comes out of nowhere.
Right.
And that can be terrifying, not only for the survivor, but for the people in their family. I think it was one thing, in that week where after the stroke where I would just start crying for no reason.
Who are you?
But I freaked my girlfriend out to no end because I've got the emotional range of a Vulcan normally. So.
Well, even they have their moments,
they have
right?
Their moments. That's right. Every 7 years.
Yeah, exactly. I think, and that emotional, impact comes also. They teach you. I used to be a cardiac nurse a long time ago. They teach you, people who have their first heart attack, particularly, successful men who never thought their bodies would fail, that never crossed their mind. Feel betrayed, and death looms, and there's all this emotional blowout. And they should expect it, but they don't. It's our job to teach them, right?
Right.
And that happens with stroke, but it's your brain, the seat of all emotion.
Exactly.
So that's going to be thrown up in the air.
So Simon, you've had quite this progression from liberal arts major into nursing, cardiac nursing, neurology, and now nurse practitioner. Nurse practitioner is one of those interesting roles that is so needed in the country these days, and yet it doesn't have its own pop culture identification yet. We understand, from an early age what a doctor is, or what we think a doctor is, or what we think a nurse is. And it's all doctors and nurses and aides on the TV shows. Not a whole lot of nurse practitioners. So what is a nurse practitioner, and how is that different from an RN or an MD?
So that's really interesting. It's been a journey even in my own mind, and I've always been aware of nurse practitioners because I liked the concept, But a nurse, there's kind of different, they call it advanced practice providers now, which is PAs and NPs. And
a PA is
a physician's assistant.
Mm-hmm.
And that has a different training, but a similar sort of role as a nurse practitioner. And a nurse practitioner is usually, traditionally, someone who has been an RN for a number of years and then can go on to graduate school and learn how to diagnose and prescribe. It started in this country and also in New Zealand and a couple of other countries with Outback as those places that don't have physicians were willing to grant authority to people with extra training, so the healthcare deserts in the country. But it's kind of taken more on, especially in the last, say, 5 years. The amount of nurses being trained and licensed has really bloomed. So nurse practitioners, from my angle, they can be different for every person that you ask. But from my angle, I think that we're trained as nurses, which means we're trained in symptom management and in education. And that tends to be more, it impacts how we relate to patients. Nurses are usually able to have a series of tools to alleviate symptoms, both in the hospital and outside in the public health world, right? And physicians do too, but that they're not with a patient for 8 hours, right? They might not fully understand how to deal with the intricacies of symptoms besides writing a script. Right? Mm-hmm. And that means that I think that as a nurse practitioner, you take those values of education and alleviating suffering and teaching a person about their disease or about their health, and it informs what you do in a different way. So figuring out what's wrong with a person, which is the diagnosing, and preventing disease, which is prescribing, adds to that, instead of that being the foundation of what it is to be a doctor. I don't know if that's a little bit too wordy, but for me, empowering people in their own health care is what being a nurse practitioner is about.
So it sounds like it starts more with the relationship with the individual patient, mm-hmm. as opposed to
the relationship
a physician role, which is more the relationship with the organs within the patient.
With the disease, with figuring out the disease. And don't get me wrong, I think pathophysiology is fascinating. Mm-hmm. I really like it. And I really like pharmacology. I really like lectures and talking to patients about drugs, side effects, and how to deal with them. But still, for me, it always comes down to sitting with a patient. And then all time stops, and that relationship is magic, both for the patient and for me. That's what it is for me to be a nurse practitioner. I think it's very different for other people, who are, raised as nurses in the ICU and that want to be nurse practitioners in the ICU. Mm-hmm. It's an entirely different thing because your patient's unconscious.
So they can't tell you what's wrong.
Right, and you can't educate them. So, it is very different.
So, as a nurse practitioner, is there what is it that you can't do that a physician could?
So I am licensed.
Or I guess that I should say that you're not allowed to do that a physician could.
I'm licensed as an adult nurse practitioner. So I had advanced training in internal medicine, and I shouldn't treat people before adolescence, so about 12 or 13 up. Mm-hmm. Others are licensed as family nurse practitioners, meaning baby to death, but they shouldn't go into specialty technically, right? Okay. And then and there are others who are midwives, mm-hmm. who are under the nurse practitioner, some of them under the nurse practitioner role, but don't do anything except birthing babies or OBGYN, right? So often our bailiwick is kind of cut off. If you're licensed to be a doctor, technically you can do anything.
Interesting. So if the licensure for a nurse practitioner includes the specialty, the licensure for a physician is not specialty restricted, although most physicians do go deep into their specialty.
So they become physicians after first year of residency or something. I don't even remember. And then they could, if they're on a plane and someone, is there a doctor here? They could, even if they're, an ophthalmologist, they can deliver the baby under their license. They might not want to,
not want to,
but they can, I mean, if someone asked me to deliver a baby, I would be kind of like, okay, but, it would have to be under the Good Samaritan law, which just covers people, that are cab drivers.
Right.
So, yeah, that's the difference. And physician assistants need to be legally connected to a doctor.
Okay.
They cannot open up shop by themselves. If they do in places like remote Alaska, they usually have a legal connection to a doctor in the city. Gotcha.
Kind of like a franchisee opening a McDonald's.
Yeah. Right. Exactly.
And that stuff becomes really interesting. I know my primary neurologist is a nurse practitioner. Yeah, I don't see any difference in the care I would have gotten versus one of the folks with the MD after their name.
Right. Probably when you were first had your stroke in the hospital, you had neurohospitalists. You had neurologists who were advanced training in vascular neurology beyond their residency in neurology. They had fellowship in vascular neurology.
Mm-hmm. Absolutely. And for the first 3 days, I saw that guy from time to time, and he was great. I have no idea what his name was at this point.
That's a little bit of a blur.
But he's the one who told me I have to stop drinking the 5-shot Americanos.
And you're like, okay.
it's like we live in Seattle, so I'm not going to take away all your coffee. But
okay,
that's fair.
Yeah, exactly. And very often, so there's very few training programs, really, if any, for nurse practitioners in the specialties. So we all have to kind of apprentice. And Dr. Praviti, Michael Praviti, is the one who apprenticed me. Mm-hmm. And he's still my mentor. I still kind of grab him in the hallway and say, okay, I got this weird thing and this weird thing and this weird thing, and tell me what to do here, and I don't understand this here, and then he'll show me how to further understand, say, an MRI, which now I feel like I'm pretty competent at until I come across something so strange, and then I still run to him, and hopefully I'll always have somebody like him.
So, I mean, what does your typical workday then look like?
So, I am fundamentally a restless ADD kind of person, right? And so that's nice. It changes all the time. In the last 4.5 years of being here in It Valley, I've sometimes started off in the hospital, or I would do rounding, or I would help the neurohospitalist.
And rounding is when you just go see a whole bunch of patients on the floor?
Stroke patients, right.
Okay.
So, and then I might not actually write up notes, but or write prescriptions unless the nurses really want something. But I would introduce myself to the patient and to the family and say, this is what happened to you. I can show you your MRI. I can tell you, that it's going to get better soon, but not soon, or this is happening right now, a whole host of things. If some conversations take up my whole, the whole time that I was supposed to be jetting from room to room, and then I get involved. Others, I just kind of check in and make sure that things have happened correctly. Vessel imaging has been ordered, that a statin has been started, things like that. And then sometimes I was working with the neurohospitalist, which isn't all stroke. Like they might say, Sarah, can you go see this seizure patient for me? It should be okay now. She's been loaded on blah, 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 blah. Mm-hmm. And then other times I would only work in the hospital, or I would only work in clinic. And in the clinic, I would see patients
So what is clinic versus hospital?
So it is completely in a neurology office. It's not people who just had their stroke. Sometimes they're in a nursing home, or usually they're home already.
So it's a separate outpatient type? Okay.
Correct, completely outpatient. Most of my work now is outpatient, though I do every other weekend in the hospital. This weekend I'm in the hospital. That's what my current schedule is. So in the clinic, I see patients who have just had their stroke a few weeks back, or sometimes years back, or sometimes I've seen them once before and this is a 3-month visit, that kind of thing. And we're coping with the stroke sequela, as you have been coping with this last...
Sequela?
Meaning that which the stroke has brought to you.
Okay.
The havoc with which it wreaked. Or I'm continuing figuring out why they have the stroke. Sometimes it's not as easy as it appears. Making sure people get those sleep studies, which people don't want to do. But as you know, changes lives.
Amazing how much of a difference it makes. Yeah. Amazing.
Yeah. Or making sure that their blood pressures are controlled. I have people on 6 agents for blood pressure alone.
Wow.
Yeah, and still they might have a poor ability to control it. Attempting to get people to go see endocrinology whose diabetes is under control. And then just dealing with all those things that I talked about. Different things come up. I tell people to go back into therapies at different times of their lives. Help people with depression at different times. Every visit is a little different.
Right. And so then that puts you then in sort of the role of helping to coordinate their post-stroke care, everything from referrals to PT and OT and speech, psych, and everything else.
Neuropsych, voc rehab, trying to get them into non-rehab ancillary programs like Tango Stride, and Tai Chi, and walking or running, or everything.
Right.
Life.
Yeah, and sort of helping to make sure they don't spend more nights there again.
Yes. And I've often sent people back to the ER. They call me and they come in for an appointment saying, I've actually been seeing double for 3 days. And
that's a bad thing.
Whatever. Yeah. Sometimes then it's like, I've been seeing, for a month I felt wrong. Then I'll just do an outpatient MRI and see if we have a stroke. Other times it's like, something's wrong right now.
Because if it's been going on for a month, there's not something any of the interventions can really do at that point.
Correct.
And that's why we have that T and B fast.
Exactly.
Get there ASAP. That's what really matters.
Encourage families to know those things, and patients and families to respect their bodies and listen and call the medics.
Right. And, and that's one of those interesting things too, because we talk about, respecting your body and knowing your body. The thing about all of this is that it's important to remember that none of this is about our bodies. When we're talking stroke, it's literally all in our head. Yeah. I mean, there's nothing wrong with my leg. There's nothing wrong with my arm.
Yeah.
Everything, it's all around that chunk of dead cells in the middle of the brain. Very
hard for people to wrap their mind around. Again, using the brain. Very hard to conceive of.
And it sort of illustrates one of those things we, us liberal arts majors encounter, back in college when we start talking about, what is reality and the nature of reality, and your perception is reality. And when your brain is damaged, your perception is damaged, and you're trying to define reality, and it's just not, it's less accurate than normal.
Right. And it's interesting things happen, like people get hallucinations sometimes of certain things are wrong in the brain. It's important for the provider, I think, and family members to remember a hallucination is created by your brain and therefore is more real than something external. What our brain tells us is our only reality, really. And it takes an extraordinary mind to say, I see that, fire-breathing dragon, and I have to know that it's not real when it looks more real than you or you, And people do have those extraordinary minds, but it's not. You have to give them credit for it. It's hard.
Yeah, exactly. And that's when we even talk about things like pain.
Mm-hmm.
Ultimately, when your arm hurts, your arm doesn't. The pain isn't actually in the arm. There's a signal coming from the arm that the brain is then telling you, oh, this signal means pain.
Mm-hmm.
And be alert and deal with this. And so stuff can get really screwy.
Yeah, it can. And that's where anxiety and depression make everything so much worse. Anxiety accentuates pain in a more tangible way than any other thing. So before I became a nurse practitioner, I was working in hospice. Did hospice care for about 6 years during when I was in graduate school and before. And that's all about symptom management. But it's also understanding, things like anxiety and depression and how it accentuates everything. And that's really has been an asset in trying to get people to work through the panic so they can get their brains working.
Mm-hmm.
And can manage neuropathies and things like that.
One of the really interesting things about depression, or one of the things I find most powerful discussions, is Wil Wheaton of Star Trek fame played Wesley Crusher. He's been a recurring character in The Big Bang Theory. He's written a lot of books. I'm a big fan of Wil and his work.
In the alternative reality world.
Exactly. He lives with depression and anxiety, and he's written about it. And the key thing is depression lies.
Mm-hmm.
So when you are experiencing depression, your brain is telling you, whether, people aren't interested in you, whether you don't really want to do that, whether you don't want, whatever it is, it's actually lying to you.
Yeah.
And you have to not trust your own brain that's telling you this.
Right. Again, with the hallucination, it's a delusion, right? Your brain's telling you this thing is the greatest reality you have, the only reality you have is what your brain tells you. And yet it's not real. You're useless. There's going to be something horrible happening every second you stop at the door. Those are delusions, but it's very hard to comprehend that. I think that is. I try to give these ideas to people pretty early on, so they won't fold into the idea of, now I'm a disabled person, which can be terribly destructive.
Mm-hmm.
I'm 40 years old, I'll never work again, I'll never function again. And if somebody tells you that early on, or if you believe it, and then you compound that belief, wow, that's a horrible future.
Exactly.
So yes, depression, anxiety, delusions, hallucinations, fatigue endurance.
all of that. Yeah. And it gets the power of language and the importance of language. And like you're saying there, I could say that I am a middle-aged, unemployed, brain-damaged cripple. Or I could say I'm a Gen X survivor and freelance content creator.
Exactly.
Both of those statements say the exact same thing, but which guy is more interesting?
Yeah.
Which life do I want to live?
Which life do you want to live? Exactly. Which life are you living? Which reality are you going to accept?
Exactly.
And project. Yeah.
Exactly. So, the way we met is after stroke, I was looking for the support groups in the Seattle area, and a friend of mine that I used to work with came across the stroke club at Valley Medical Center in Renton, a suburb of Seattle. Mm-hmm. And you've been running that group for a while. So, what is it you like about that group? How did you come to run that group?
So I had been a nurse practitioner in geriatrics. I had been a nurse in chronic disease management, hospice, all this cardiac, all these other things, and then had this kind of deeper knowledge about culture, literature. And I wanted something a little bit more for my career. I went looking for it and came across stroke. And it was going to be a big learning curve, neurology-wise, but I thought I was up for it. And what I wanted out of Valley was a place in South King County, which is the stroke belt of around here, right? And is kind of this fascinating population filled with extraordinarily diverse people, both economically and across the world, from across the world.
And for those who are not local and aren't as familiar with the area we're talking about, South King County, very different from your perception of Seattle. It's a very different community that still incorporates everything from the suburbs to some of the more industrial blue-collar work, some Boeing work, the ports that are out there, as well as draws from some of the rural communities and farming and agricultural communities that are out there as well. So it's not just an Amazon satellite.
Right, not at all. Though that as well, perhaps.
Sure.
It's everything. So that was really fascinating to me, and I thought that it was a great population, and my idea of post-stroke care included people who had just had strokes, preventing people from ever having strokes, and coping with stroke throughout the life, right? And so I thought that connecting all those things, the survivors, if they could thrive, could then become the perfect vehicle for telling their neighbors and their family members what to do if you have stroke, and what to do to prevent stroke. And so it all was a wonderful circle of public health kind of thing. And so post-stroke, I think people don't have maybe as much community as post-Parkinson's, for instance. They have all this money and they have all this, and even, other more, in some respects, more devastating things like Alzheimer's. Has a lot.
One of the neurologists I've worked with has described stroke as the least sexy of the neurological conditions compared to the Parkinson's and the MS and the ALS folks. Nobody's dumping buckets of ice water over their heads for us.
Right, at all, and they should be, because it affects all of us to some degree, and it is. I wanted just to educate and support the survivor population, because I think that there's a lot of kind of misplaced morality. Like, if you had a stroke, it's because you ate too many Twinkies. You know what I mean? Maybe that's a lot of fear on the part of the population who's like, that's the last thing I want to have happen to me. It's not going to happen to me because whatever. But
right, and I think the other perception that people have is, well, I had a stroke, that means I'm old.
Right, exactly. Or else, it's too terrifying. But in any case, so when I became a nurse practitioner, I was starting to learn neurology, seeing people in the hospital, and started seeing them almost right away in clinic. I connected with some people to make sure that the stroke club was going, and it was fading. It was under rehab. So I think in other communities, very often it's strictly under rehab, that there's a physical or occupational therapist who run it. It tends to be during the day. It tends to be connected to acute rehab programs. And we didn't have an acute rehab program here. And all therapists in the clinic world are under pressure to not take time off work during the day. They just, all people in healthcare, right? You have to do, every minute has to be accounted for, because that's just the economics of healthcare. And so I started going to these monthly programs, and then the rehab basically couldn't fund it anymore. So I moved it to the evening. Some of my patients could come, even those who were at work, and I could fund it. So that was 4 years ago. 4 years ago. And so it's been at that spot, that time, since. And I think that's really important for a survivor group, is consistency. So that some people can go routinely for a year, and then they feel like they don't need it, and then 2 years later they're like, oh, I really need to talk to somebody about this, and they can just show up, and they know where it is, and they know when it is. And I think consistency really helps. So that's how I kind of fell into it, is that I believe in its vision. I believe it's really that people who have this challenging thing should have a place to go and talk to other people, even if it doesn't have kind of sexy money attached to it. And yeah.
So, I mean, it's been growing since that time, and it's the largest I've seen it.
Really?
In the last year or so that I've been year and a half that I've been going. How do you keep people coming back, or what do you see as best practices for running a group like that?
So I think including people in the community. So every time you ask a speaker, they get jazzed about it, So somebody from the rehab department of 2 therapists wanted to start Tai Chi. And they asked me how to help them start it, because I had some knowledge about how to set up rooms and how to get advertising stuff, because I had done this with stroke. And then Gabriella from Tango came to one of the Tai Chis.
And we had Gabriella on the show about a year ago. If you want to go back and learn more about Tango, strokecast.com/Tango.
And then she got introduced to me through these therapists who were doing Tai Chi, and she asked me if I could explain what stroke was to her. She realized that she thought she had a vision of it in her head, and she wanted to understand better what was safe for her to do with patients and that sort of stuff. And then after a year of that, helping kind of that program kind of get started. I didn't do much in the program, but I helped her get launched. And she sent one of her regular patients, regular clients, I guess, and dancers, and then to the stroke club. And that time, April and her husband would happen to be there, and they're like, yes. And then they went there. They didn't come to stroke club for much of the next year, but they routinely went to Tango, and then they just came back to stroke club. And I'm sure they will help encourage somebody else to go into Tango, and that it blossoms out like that. But you definitely need to remind the neurologists and the neurohospitalists and the nurses on the floor and the social workers that this is out there for people. And sometimes I'm good at that, and sometimes I get distracted. Sometimes they're good at that, sometimes they get distracted. But it takes on a life of its own eventually, I hope.
One of the things that I think that comes out of that is that you see a lot of the same value from a lot of the different stroke groups, but every different group I've been a part of ends up with its own distinct personality of the way it functions and the way folks interact.
And that's really interesting. I didn't have a lot of training or knowledge of how to make a group. I just wanted to make sure that it didn't get pigeonholed into one view of stroke, which is very easy to do. The neuropsychologists come every once in a while, and they had done that. They had groups during their training, and it was all cognition and emotion. It was 100% emotion, really. And the therapists have run groups, and it was all rehab. And of course, Tango, Tai Chi, it's all about having fun post-life, And I think there needs to be a larger circle where all of those people, even people who, are doing the 100-mile bike rides and are, cognitively intact, then they still feel like they can come and they have a place, as are the people who are living in nursing homes and have to be wheeled in. So if I can help create a format where those two people can talk to each other and still feel like they get something out of stroke club, then I feel like I've done something.
And I think that's really interesting too, where you talk about that, how each of the different specialties that might run a group is naturally going to bring their own flavor to it. And it's not an intentional change, it's just if you're a PT, you see the world through a PT frame. If you're a neurologist, you're going to see it through the neurology frame. And I think this kind of holistic approach that you're talking about, that seems to lend itself to the idea of what we were talking about earlier, the role of the nurse practitioner, looking at the whole person and focusing that in.
You might be right.
So you've been, as we were talking about, you're transitioning out of that now as you're sort of taking a bit of a sabbatical from the in-hospital role and your current role. Why now?
It's purely personal. I've been working for a long time. I want to just take some time to myself. I have some writing projects I want to do. I have some hiking that I want to do, and I want to rejuvenate. And then I really need to know what my relationship with healthcare is. Healthcare is a very difficult field, not oddly enough because of the patients, not because of the difficulty of end of life or debility. I'm grateful for those conversations, but because it's a hard world in terms of how much energy it takes, how much time it takes. And so I'll probably come back to it part-time.
Okay.
But I'm not sure yet.
Sure.
I'm going to empty my head first and then pick wisely.
Well, yeah, I mean, it's certainly an intense space, from everything from the bureaucracies to the details of making sure everything gets done right, to the politics associated with it, to all of this stuff coming together. And I mean, one of the things I like about being in marketing is that if I make a mistake or something a meeting gets canceled or a program gets canceled, well, nobody's going to die if I screw up.
Yeah.
Can't say the same thing about healthcare all the time.
Right. And it does. I mean, these programs. It's massive systems, and it's a little demoralizing to feel like a cog in a bureaucratic machine, especially when each cog, holds so much training and knowledge. So I just have to get myself straight and then figure out.
And the wilds of Alaska, away from civilization, seems like a good place to do that.
Indeed, and going way back to my first degree, American Studies, I've always wanted to see all 50 states. I'm not that far off, but I have never been to Alaska. So I'm also going to. I'm up to about 45.
That's pretty good.
Yeah, going to a Mayo Clinic conference in September in Rochester, Minnesota, which is the heart of Mayo. And I'm going to go to Nebraska and do a Midwest and hit some of those. So I might end up closing the loop.
Nice.
Yeah.
Nice.
So again, that's purely personal.
Absolutely. And there's all sorts of great things happening in those different areas.
Yeah.
One of the things I've been finding is that as I've gotten deeper into this world, was just connecting with people in all of these different places and being able to ultimately figure out, well, I need to get to Nebraska to go have lunch with those folks or wherever else.
Yeah.
So it's a fascinating network.
I'll bet. Yeah, I agree. I don't think I could give up healthcare. It would be too huge a loss, because I really love connecting to people.
Awesome. So Sarah, this has been absolutely fantastic. We got into a lot of areas that I never expected to, which is always my favorite thing to have happen.
Good.
So I think that this has been great. Thank you so much for joining us this week, and thank you for your time.
Absolutely. It's been a pleasure.
And that brings us to our hack of the week.
So, it sounds a little theoretical, but I always tell people a nap is free medicine. A nap is free medicine. And I don't mean that just in, prescribed during your day at 2 o'clock every time, but if you're not functioning right, then it's time for a reboot. And the nap is the best reboot for neurological problems. And that's not always possible, but it's good to keep in mind that I'm not falling apart right now. It's just that it's important for me to have fluids and plump up those vessels, and it's important to have the right sleep because the brain can only fully function in sleep.
It's quite significant how our roles define how people see us. Prior to our chat, I never would have guessed that Sarah had a liberal arts background, was the child of immigrants, or spent time as a cardiac nurse or hospice nurse. I mean, granted, none of this seems out of character, but once we meet someone and put them in a certain bucket, that's how we see them. Nurse practitioner and stroke clinician facilitating a support group and treating patients. The lesson here on one level, of course, is to recognize that members of our care teams are individual people too, with their own stories and their own paths. We may not see or hear those stories in our brief interactions, but they are there, and they shape the people that we deal with every day. Perhaps the more important lesson, though, is to understand how people see us. Others meet us and put us into their own limited buckets with their own perceptions of what a stroke survivor is, or what a caregiver is, or what an OT is, what a PT is, what an SLP is, what a doctor is, etc. When people make limited assumptions about us based on the role in which they encounter us, it's easy to become offended that they're not seeing us as a whole person with a history. But give them a break. I mean, we do it too. It's part of human nature. It's part of the way we just categorize and understand the world around us. And recognize that view, that process, really goes both ways. There are a lot of things to unpack in this conversation. Sarah talked about helping survivors grieve for their previous life, because this new life is different, and it can be a sharp break from our previous one. It's a concept I've heard before, and we've talked about in previous episodes. But the new concept for me was when she talked about her cardiac patients feeling a sense of betrayal at their bodies. It's the betrayal we never expect to come. As someone who's always been comfortable thinking in brain space, whatever that means, and who identifies as Ravenclaw, the stroke does feel like a betrayal. I mean, I was never an athlete. I could barely strum a couple of notes on the mandolin, and I've never been the life of the party. But I have been a big reader, and I love thinking about big things. I was always a good student, and I can get lost in daydreams and playing out all sorts of scenarios in my head. I can write and share concepts and stories. Throughout my life, I've aligned myself pretty closely with the idea of mind work. And then my brain betrayed me, in part by partially dying. You see, our lives can be turned upside down, not from the outside, but from the inside. And that makes that sense of betrayal just that much more severe. So, on that cheery note, what does Sarah's story make you think about? Go ahead and let us know in the Strokecast Facebook community at strokecast.com/Facebook group, or just head on over to strokecast.com/Sarah for that and all the links we talked about today. To find a local stroke support group in the United States, visit strokecast.com/find-support to find a group near you. Follow Strokecast on Instagram by going to strokecast.com/Instagram or searching for Bill's Strokecast in the Instagram search engine. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The The Strokecast is a proud production of the Currently Speaking Podcast Network.